All right, so I'm going to lean more on the PI side of this AI for PI, and I'll be the first person to tell you that I'm not an AI expert. I am pretty much a healthcare expert. I've been doing this my entire career. And I'll tell you right now that I'm actually shocked that I'm talking about payment integrity today. So I thought I left payment integrity behind in my career about 12 years ago. A little bit about myself. I've done all healthcare in my entire career. From undergrad, I was a healthcare economics major. I quickly went through an actuarial exams, and I had this epiphany. I think this was like I'm going to date myself terribly now, but before the year 2000, that the trend in healthcare was escalating much faster than the GNP, right? In that era, it was like 12, 14%. GNP was even like 3 or 4%. Like, what's going to happen in the next decades? And in fact, from an actuarial perspective, we were trying to figure out how do you allocate money today for future healthcare spend, and it was going to consume the GNP, right? So from a very early part in my life, I've had this compelling urgency to say, what's going to transform healthcare? Because something really disruptive has to happen in healthcare, or else it's going to really consume much of what we do in our lives. And you can see it today. You watch TV at night, every commercial is about pharmaceuticals, right? Everything that you're doing is about healthcare. Is now 22% of the GNP, right? It is happening just as I had predicted way back when, and something has to change. So I have been myself, my personal career, on a mission to try and figure this out. And I thought, I got my MBA in healthcare. I'm going to do value-based care, just like we just heard AJ talk about. And I was like, okay, we're going to do episodes. We're going to figure out how to incentivize providers to want to do something to keep patients healthy, about being about healthy care instead of about sick care. And then I realized that, that's not paying the bills. And I had a baby to take care of. I had mortgage to pay. And guess what pays the bills? Payment integrity, right? Because that's like creating results much quicker, and it is realizable savings, and people could actually spell payment integrity. People didn't even understand what value-based care was back in that time, and the results are too late, right? So payment integrity creates results right in front of payers, and when you're evaluated on the next quarter's earnings, payment integrity matters, right? So I started working for Change Healthcare even before it was Change Healthcare, and I was part of the little group of people that invented what's today Claims Extend. So does everyone know what Claims Extend is here? Yes? It's a claims editor that is now a utility that is probably sitting in the vast majority of healthcare payer systems across the country. And I'm very proud that I was part of the little group of people that did that. So I've been across all the payers and practically every blue in the country, figuring out the solution of their Claims Extend system. And at the time, it was transformative, right? Because it went from the shrink-wrapped disc that used to put into the healthcare payer adjudication system once a year with very manual updates, to something that was a 3-tiered architecture. It was flexible. It had a data dictionary. It had a rules-based Boolean logic in it. It was beautiful. It was transformative, right? And for those people who remember what claim check was, this was a whole new world, right? And it changed how we thought about payment integrity inside of a payer. Which remember my husband saying that I shouldn't talk about this at cocktail parties. I can get excited about this, right? So I did that for 12 or 13 years. I went to all these payers across the country, and I remember this last payer I went to, I think might have been Primera, and the actuary said to me, the water comes back to the same level. And I said, what does that mean? He goes, it's a whack-a-mole game, right? Like, you're going to take out money here, it's going to pop up over here. Or you can think of it like a Cold War, like we're building up our arsenal over here, and the providers are building their arsenal over there, and we're making more money in health and like more spend on healthcare. Isn't that true? Right? And at that moment in my life, my father was really sick. He was in the ICU, and I went into the room with him, and I said to myself, I've dedicated my career to healthcare, and none of this is helping him, right? All the patient care that I thought was really important, and value-based care, keeping patients healthy. Payment integrity is just adding more cost, right? And there's almost a fallacy that all these savings are really savings, right? So I took a 180. I actually left his ICU room, and I called up my boss and I quit. And I went to a different job working at Cigna, and I ran value-based care. And I said, this is what we're going to do. We're going to really get back to basics, and we're going to incentivize providers to do the right thing. We're going to keep patients healthy. We're going to, create all of this collaboration, reward them for good outcomes. Did that work out so well? Maybe not, because all of these big companies are, again, rewarded on the next quarter's earnings and things that really keep patients healthy for a longer term, not so much as where they want to invest. They actually went back to, maybe we should do more payment integrity, right? Because that's going to help them to be more successful. So I really got jaded by the whole thing. I don't mean to be depressing. Left that to go back to a startup and go back to value-based care. That didn't work out, and now I'm consulting. But the interesting thing is that the thing I'm consulting about is payment integrity, which is something that I left a long time ago because I really didn't like it. I thought it was this whole whack-a-mole Cold War, this thing that is not going to really help patients. But you know what? Today I'm more excited about payment integrity than I've been ever. That's what I'm excited to tell you why that is. I think that what we're going to talk about today is really going to change it and put more money back where it's supposed to and back into patient care. So let's just start with some of these numbers some of the same ones that Mishir talked about before. But just imagine for a second that $1.25 billion that we spend on payment integrity is going to patient care, right? Or imagine it's going to be $14 billion by 2034. Is that where we want to spend our money in healthcare? I don't think so. I think there's better places to spend money in healthcare. But we still have it. Why? Because there's still payers who are still struggling with trend, right? There's but we're creating all this abrasion with the providers who are touching our patients. Nothing that the payers are doing is scalable. And as we just talked about, there's a million vendors in this space, and they're all trying to get a piece of the pie because why not? Because there's a lot of money in healthcare now, right? So what I want to do is go back to what is payment integrity and maybe start with what's integrity. And my mother always told me that integrity is saying what you're going to do and then doing what you said. Right? So kind of put the rules out there, agree on the rules, then abide by the rules, do them the right way. So let's try that with how we pay claims, right? Think about how the rules are with how we pay claims. The rules come out in the form of coding guidelines, like NCCI, medical policies, reimbursement policies, the contracts you make with your providers, and who you're paying claims on. Those are all just rules, right? Like how I'm going to pay the claims. And now we've created all of these functions inside of payers that try to enact those rules, right? We have claims editing, coordination of benefits, all sorts of coding validations, sub-row and COB and SIU. There's a million functions inside of a payer that are there to make sure the rules are followed, right? Now it looks like this, right? And this is I would say, a tame version of what it looks like. So what I do as part of my job is to go into a payer's ecosystem and say, hey, tell me all the places that you do payment integrity. So what do you observe about this picture? Anybody? Okay, easy one. Everything's on the right side of the page, right? Everything is post-pay. And then this is a real payer that I did a couple of years ago. And you could see that they do most of their activities post-pay. Another observation is they do things themselves. They do things with vendors. Many times there's multiple vendors doing the same thing, and they're all over the place and very fragmented. You heard the word fragmented this morning a couple of times. That is very true inside of a healthcare payer. And sometimes you have a prepay team and a postpay team who never talk to each other, who might be doing the same thing and have different goals, and they're working against each other, and they don't even understand what each other is doing. All sorts of inefficiencies. And as well, the data that's flowing through this whole system is compromised, right? So all sorts of issues to be had inside of the payer system. So what are we going to do to fix this? We got to modernize this, inject technology. And again, I'm just going to preface this by saying that I'm not a technologist. I just know a lot about payment integrity. So you'll have to just bear with me, and we'll imagine how technology will affect this. So first, let's put some guiding principles together. First, my first principle is about integrity and making sure that we're communicating what we're doing. We're following ethical and standards on how we're doing it. This isn't like a game where we're trying to win one on the providers, right? We're trying to be clearly communicating what we're doing and trying to follow those things that we said we're going to do. But let's not be gullible. We know there are some bad actors out there. There's definitely always a need to have payment integrity, right? There's definitely providers who are not following the rules. We do need to have standards. There's definitely miscoding going on out there. So we have to figure out how to do that and figure out how to get to affordability, because affordability matters, not just to the shareholders, but to patients. And we can't continue this escalating trend and make things unaffordable for patients. Not to mention from an administrative perspective, the vendor contingency costs and these people who are involved in payment integrity that Mashir talked about earlier, they're just adding to the drain on healthcare. I mean, it's kind of shocking that a provider has 4.5 people for every 10 people that attend providers in the system who are just managing claims. Like, what's wrong with that? The third is mitigating provider abrasion. And I'm very encouraged by the fact that I see more and more payers saying, like, why are we at odds with each other, with the provider? Aren't we on the same team, just like AJ just said? How do we figure out how we work together? Because in the value-based care world, I do want to work on the same team as a provider. Right? And in many payers that I work with, they have all these value-based agreements with the providers who really just want to get paid, right? They want to get paid for the service that they did, and they want to get predictable payments, and they want to get payments in a timely way. And we're trying to collaborate with them at the same time we're not paying their claims. Like, how can the right and left hands be not talking to each other like that? The fourth is we have to be a balance. Like, it's many payers just resort to, okay, we'll just like default to manual, right? And let the people take care of it. And they'll look at every claim. Well, all those high cost claimants will just have people look at all in all. Well, that can't be, right? How can we have people doing everything? We need to figure out how we're going to do things in a timely way. And I think technology and what we're talking about today is going to solve this. And then we have to do things in a timely way. We have to do it with within the right windows, because claims expire. We only have so long that we can recoup things. So we have to use automation in order to get to the most efficiency and the most opportunity within the spend. So there are 3 principles that I've been working with the payers about, and they go like this. The first is this is not that novel, moving left, but my suggestion is that we're not moving left enough. How far left can we go? That's the first thing we're going to talk about. The second is moving in. And when I say moving in, I don't necessarily mean doing everything yourself. I mean being smart about what you're moving in, and taking control and being precise about what you're doing inside in your house and what you're using vendors for. And the third is just being very transparent and communicating and being collaborative and really like working with your providers in a way that you haven't before. So these are the 3 tenets that we're going to talk about in the next, keeping myself honest. How long do I have? Okay, we're doing okay. Okay, the first is moving left. So let me just talk about claims editing, because this is my background, it's in my DNA. And I think most payers think about that far right of the payer adjudication system and moving left just post-pay to prepay. Okay, I think we've been talking about that for like 10 or 15 years. And that does, and there's definitely things that you still have to do post-pay, because you want to look at trends across a long period of time, or you want to, be able to create provider insights about using modifiers and things like that. Maybe you need to do a little bit of that post pay, but what can we bring into a prepaid place? I mean, mind you that my background is in claims extend and the Boolean logic in there. There are hundreds and hundreds of Boolean if then else statements, and then there are millions and millions of, I feel like I'm talking about the cosmos, of codes and code pairs behind that are maintained by an army of people that sit in this prepay place. And it is kind of miraculous that we can go through claims and in milliseconds, go through all those hundreds of rules and millions of codes and code pairs. And that's what Claims Extend does. And we should bring more and more of what is post-pay into a prepaid place in order to do that. But my push is, well, why couldn't you do that even earlier? Go into the gateway and figure out how to do it in the clearinghouse, and maybe not even let a claim in the system that's going to hit one of those rules. And then I'll push you even further to say, like, well, why couldn't you do that before that claim ever left the provider's practice management system? Why couldn't you anticipate the edits that are going to happen at that payer's adjudication system and let them forecast how that claim's going to get paid and not send a bad claim? Because when they send those bad claims, what it was the number we share, $17 billion in reverse and reprocessing that happens, right? Because the providers are sending miscoded claims, the payers are denying those claims, they're sending it back to the providers are fixing it with those 4 people per 10 providers, and then they're pushing it back to the payer again. And this is continuous cycle going around and around. And here's what happens. So imagine there's 100,000 cases of claims that were miscoded for modifiers. That's a typical editing rule that's one of those inside of Claims Extend. And let's pretend there's $100 per each one, and your PI vendor comes and says, I've got $10 million for you of savings. Whew, okay, we're gonna make $10 million. So what really happens? Well, you put that edit in, and then half the time, let's put a real example around this. Let's say it's there's 2 modifiers on this line that are mutually exclusive, or maybe it's diagnoses that are mutually exclusive. You're going to deny it, and the provider's going to send it back in. Well, half the time they're going to fix it, and they're going to say, "Oops, I just put the wrong modifier on. Darn, here's the right modifier." They're going to send it back in, and 5 million of the 10 million goes away, right? Because they fixed it, and it's going to get paid. But what's going to happen? Your vendors took 15% of that $5 million, and you're going to pay them $750,000, right? And then 50,000 other cases are going, half of them, they're going to keep trying and trying and trying and trying and trying to resubmit it. And we've looked in the data, and we can see the payers are seeing these claims sometimes 8 and 10 times. I was being conservative with 4. Providers just keep trying to get those claims right. And say it costs $10, which is also conservative, for every single time that payer has to touch it, times 4. And that's $2 million that is now sucked away in SG&A costs. So that $10 million, well, $5 million goes away because they were coded correctly. The other things, the amount that is savings, you just pay $2 million for, and your net is $2.25 million. So what you thought was a lot of money really is not. And then here's the kicker that I love the most, that providers aren't dumb. You just didn't pull the wool off of the provider over their eyes. They understand that they just lost $5 million out of their pocket. And when they come back next year to negotiate with you on your rate increase, what will it be? They will bring back this number onto the negotiating table, and they will ask for that amount back into their rate increase. And we wonder why these rate increases are now 12, 14, sometimes 18%. Because we haven't paid them, obviously, and they're looking to recoup their money. So this is what's happening in real life. Here's an example of COB. So COB today, traditionally, I think it is hysterical, and I get like letters in the mail asking me on paper to fill out what if I have another coverage, or whether this was involved in an accident. Like, can you imagine the data latency that we, like Ada just talked about, and all the inaccuracies and manual work that goes into it. Can we move COB from post-pay to prepay, at least, so that we're accessing data at the time that the claims are getting paid, and we're really accessing the source of the data to eliminate those manual touches in an API call to the source in order to get the right patient on that claim from the beginning? Or even doing it even better and moving all the way upstream to an EMR where you can, at the time the claim is being sent, check the patient's eligibility against the source. This is all really possible with everything we're talking today with AI. I'm not the one who will code it, obviously, but I can imagine that that all of those paper transactions with people, with the data being dated by the time it actually gets back to the system, are going to get eliminated by pulling this all up front. Now, let's talk about number 2, which is moving in. Moving in, I'll just remind you, I don't mean it to be about moving everything in-house, because I think people get nervous when I say that, because it's not about hiring lots of FTEs. It's not about building everything yourself, because payers, like AJ was saying, they shouldn't build everything themselves, right? They're not really good at coding and all the things that some of these vendors are really, really good at. So they should outsource, but do it judiciously. Be smart about what you're outsourcing and what you're bringing in-house. So when I work with the clients that I work with, we talk about, well, what are you trying to eliminate? Well, I'm definitely trying to eliminate the provider abrasion. Some of these vendors are just creating a blanket policy about readmissions or about ED coding, about NICU, whatever they're looking for, because really from their perspective, the more they catch, the better, right? If they're paid contingency, there's a lot of abrasion. They're trying to minimize contingency payments. The integration of every one of those vendors takes time and money, and they create like a really black and white rigid process. So how do we balance creating precision and control to managing how many people you're employing and how long it's going to take you to do it, with really, when you're hiring a vendor, you get expertise. Right? Like, I remember when I was at Cigna, we had a lot of people who spent a lot of time looking around the market to figure out what's going on in the PI industry, like and really being good about all the edits and bringing the industry knowledge. But that's a national payer. Can you imagine some of the smaller payers having the wherewithal to have that all expertise? That's probably not going to happen. And then they have to really balance how much they can spend and really in-source in terms of technology. So from a claims editing perspective, you can't imagine vending out trying to bring in-house all that content management, or keeping abreast with everything that's going on in PI. So you might want to outsource some of that, but doing it a little bit smarter. So this is a little bit about clinical auditing, which I'm not sure how much everyone in the room knows goes on here, but like very often payers are denying claims that they suspect are upcoded. They need to look at medical records. They're having MDs look at these things. It could be very manual, and it could be vended out in a very slow process. So what we're imagining and working on with our payers is, how could we use AI in order to be smarter about what we're going to stop? So we're not asking the provider for every single claim with EMR, and then being more thoughtful about how to connect that claim that you've selected with the policy that it has invoked, and then the EMR that you are now looking at, and triangulate that in what could be minutes or seconds through AI that would have taken a person hours to do. Right? So I'm going to say that again, because it's very impactful. And I'll even give you an example. That one of the payers and providers that I am working with in a collaboration, the provider said, my biggest pain point with you, payer, is this ER upcoding. You're killing my team. And you're denying at almost every single ER visit that was at a certain level, and asking for medical records. My team has to go get that medical record and send it to you. It's the number one request for information that this provider had. The payer had no idea this was their problem. Like we sat them at the table together and we showed it to them. Like, do you know how many medical records you're asking for? These are the 4 people per 10 right here. This is the number one thing that they're doing. They're sending records over for a person to go look at and then manually look through this, what could be hundreds of pages, right, to understand what in the policy is being is it invoking, and then connect it to the claim. So imagine if you can triangulate that in one fell swoop with AI that can connect all that together, or maybe do that in the workflow, right, in a prepay way. So that's where we've moved this payer to, is how do we do this prepay? How do we figure out how to almost anticipate sending the record with the claim, have AI read the record, and then push that claim through workflow in a leveled way automatically. The third tenet was about provider transparency, and this one is one that I'm pretty passionate about, because I feel like you need to tell them the rules, right? There should be an answer key that you're giving out all the time to the providers. There shouldn't be a secret, and this idea of having a black box where your edits are feels like we're kind of scamming the providers. Like, that's not why we're here. That provider provided a service for your patient. Right? We need to pay them, and pay them in a predictable way, in a way that is in a timely way. That's all I want, right? So we have to communicate the rules. Like, here's my rule about readmission. Here's my rule about E&M of coding. Here's when I think it's appropriate to use NICU. And then stop things that are just a burden on providers, like these edits that keep getting overturned. Prior auth set, sometimes we look at the prior auth data. Some of these are always approved every single time, or they're always overturned. So just remove those things, reward providers who are doing the right thing, and tell them what the answers are. So what we've been working with some of our payers to do is to stop the blindsiding of the providers. How can we think of this like product management? So who does product management in this room? You don't do it willy-nilly. You just don't put changes into your system every week. That's what we do to our providers, right? And in fact, like, our payment integrity teams are incentivized to do that, because they have these huge numbers they have to go after. So the faster they can put in these new rules, the better, because they get more time that they're up and running. What is that doing to the providers? The providers are getting, oh my gosh, today you're ED upcoding, you're doing this, and tomorrow you're doing that, and then I can't keep track of how to prepare. So we're working with our payers to say, like, look, let's make this more methodical. Let's make follow CMS's lead and communicate the change, get their providers' comments, figure out a go live date, and then work in a kind of a release schedule, and that's predictable. So this is about ED upcoding. And this bar chart, can everyone see this on the bottom, is from 2004 to 2021, how the percent of ED E&Ms has changed. So in 2004, 5% of ED E&Ms were level 5. In 2021, 20% were level 5. Right? 18% were level 4, and 35% were level 4 in 2021. So a full 55% of ED E&Ms are, and probably more today, are upcoded, right? Are in 4 and 5s. We don't know if they're upcoded. So I mean, obviously this is a trend, right? Like, we have to, and to my second guiding principle, we do need to be thoughtful about affordability and what's going on here. Like, we can't keep not turn a blind eye to it, and you do need to do something about it, right? So is it the right thing to do what I just talked about, that payer was doing, to deny all 55% of them and go ask for medical records? Like, does that sound like it's tenable? Just adding more people to the process, and that time it takes for someone to look at this EMR and then associate it with the claim and figure out what the policy said. Oh my gosh, how much time it would take them to do that. How can we change this whole this scenario to be something that it could be automated? Right? So first we determined a policy, right? So it's like my number 3 tenet of my guiding was communicate, right? We got to communicate and agree on the rule. So first we made a policy that said these diagnoses don't go with these levels, right? You're having your nail debridement does not go with a level 4 E&M, right? Okay, I think we all can agree on that. Communicate that policy. Tell the providers, here's what I'm going to do before you do it. What a concept, right? And we're going to do this in 3 months. So get ready, because you might have to have people send records. You might have to, anticipate that this change is going to happen. Then we move this from something that was a post-pay process that was done through that laborious team to something that is prepay. And we automated it, and we figured out how to do it even without looking at medical records. And then we said, okay, we don't, now that we've exposed the rules, the very frequent pushback is, well, now the providers know, right? And they're going to go around it, and they're going to figure out how to game the rules. Okay, like that's a little bit fraud, right? But if you think that providers are going to be like that, let's monitor them and see how this is going to change over time, because we should then see that their levels will even out. And if they're doing the wrong thing, then we should see that in the data, right? So that's what we did. And it looks something like that. We help the provider to say, okay, this payer to say, like, look, we're going to do this ED upcoming upcoding initiative. It's going to go into effect on 1/1. The notice date was 1/1, and the effective date would be 4/1. And we said to, like, this is to provider what it's going to look like historically on your claims. And then later, after this has been in production for some time, on the right is what we want to see happen. And what you should be doing is continuously talking to your providers and saying, here's what's going to happen, put it in, here's what happened, right? And there's this continuous feedback loop so they can understand the effect. So a little bit about future state vision. I showed you, like, I called it my Frankenstein picture of all of the fragmented places inside of the payers organization where there is PI. What we really need is to consolidate, figure out how to bring the silos together and create governance and an organizational structure that would support this. So really defining a North Star that you're going after with PI. And maybe the North Star is about not having as much PI. How do I figure out how to make sense of that crazy picture and have some executive governance around it? Last time I talked about PI was at a Blues conference last fall, and I just, for kicks and giggles, asked the audience where in the organization their PI function sits. Who do they report up to? I must have gotten 8 different answers. Right? They report to all different places in the organization. They're so fragmented, they hardly talk to each other. And like I said, sometimes the pre and post teams are working against each other. It is kind of chaotic. So one of the things that we do with our payers is to figure out, well, how do we figure out governance around this? And what are all the bottom layer, the tools that you're using? They usually have first and second pass editing, all these vendors, COB, like where are all these things? Who is involved in all of these things? Who are the functional groups across the organization? But most importantly, what's the source of truth? What are the rules that you're trying to follow? And how do we expose the rules and make them very transparent across the organization? This might differ by different functional areas, lines of business like commercial and ASO, and sometimes challenging misaligned incentives between the two of them even. So we try and figure out how do we get to some alignment there, but we're stronger together, right? Than all of these groups working against each other and figuring out their own solutions. How do we figure out how to create one organization that can work as a team? And then create dashboards, monitoring, KPIs, roadmaps together so that we can go to our portfolio planning process and say, this is what we need to make a stronger PI world. And then try and get to a picture like this. So moving things to the left, how do we get from post-pay to prepay? Figure out how to get rid of some of these vendors and consolidate to a few vendors that are doing more innovative, more tech-enabled kinds of PI approaches, and less of the just blanket black box contingency-based approach. So that's where we're working with our payers to figure out how do we change that picture and make more sense of it. And lastly, this is my favorite picture. How do we get to here? Because what's going on, if you look at the right side of the page, this is the payer in the gray, most of their work happening post-pay, and that like hump going to the right, and the provider on the left, who's doing all these RCM processes. How can they meet in the middle and create value? How can they get to a place where the RCM processes are anticipating the PI processes and using AI to do that in a way that we're really creating lots of opportunity in the system? Because I just think about that $1.25 billion that's being wasted. How can we eliminate that and get to a place where that's going back to patients? How do those 4 people that are working at that provider, how do we translate that into four people that are working with patients for that provider and not recoding claims? So getting to a place like this is what's success to me. And I'll tell you, like at that Blues PI conference, I asked at the beginning of that conference, how many people in that room have a target on their head? And every hand went up in the room. They all have a number that they have to go after. And when there is a shortfall, who is the first person that is asked to go fill that shortfall? The PI team, right? Because it's savings that you can get fast. So you don't have to negotiate with the provider. You don't have to wait for a contract to open up. You don't have to change behaviors. You don't have to change referral patterns. It's kind of the place where you make savings fast. And that's why PI has always been the place where people go to get savings. That's why they have these big numbers that are stuck on their heads. But those numbers are a little bit of, a misnomer, right? Because they're not real savings. Like I said before, those providers are not dummies. They know when you're taking money out of the one pocket, they're going to get it back in the other pocket. The water comes back to the same level. It's a whack-a-mole game, right? That's what the moment that I stepped into my father's ICU room, that was my moment that this isn't real savings. This is a fictitious thing that we're going after. Don't get me wrong, there's waste in healthcare. There's definitely that EDF coding, like I showed you, that you need to fix. But how do we be more thoughtful about fixing the right things and not being overly aggressive on the wrong things? Being more transparent with our providers about what we're going to do, be collaborative, be communicative about what's going to happen, work with them to send in the right claims in the first place. And remove that waste from the system so we can really optimize how we're spending our money. I mean, there's clearly other ways we can go after. There's an arbitrage in pricing. There's low value care. There's failures in how care is delivered. Those are the things we should be spending our money trying to fix. This we can definitely do by injecting more technology into how we do PI. So in my world, those aggressive savings targets should be gone, and we should be striving to get to zero. Right? That's aspirational, and for sure, I'm being a little bit dramatic, but why not? Those pay and chase processes need to be transformed to things that are never resubmitted. All those vendors that we work with, we need to optimize them and reduce all that contingency payment. We need to work together with the providers because they're creating the care for the patient. They're the ones that are touching our patients. Be upfront with the providers. Don't put things in a black box. Don't be fragmented. Be cohesive. Have a governance around everything that you do. And you know what? Remember that these savings are not really savings. They're going to come back and hit you in the next rate increase. So let's all just be honest about that and figure out how we can do this in a judicious way that will, in my lifetime, maybe eliminate or minimize PI and create more open, communicative, transparent ways of maybe using artificial intelligence, using predictive models to be able to pay claims correctly the first time. So I left some time for questions.
So one of the strange things is that there are still elements in the chain where the business model is number of transactions, right? So the revenues off of transactions, where there's a disincentive to make the system more efficient and and moving it to the left. Can you comment on what it's going to take to finally get rid of that? I'm thinking about even some of the gateway vendors or things where, the having 5 to 10 cycles actually is potentially more profitable.
Yeah, and that's why I would challenge us to say, like, can we even go further left than the gateway vendors? Right, because I don't think that's far enough, and I had this conversation with someone last night, right, at some dinner, right? Yes, I think the gateway vendors are not still have the wrong incentives. If their incentives are per transaction and they want those claims to keep coming back, then they're still part of the problem.
Yeah. And then I think the second question, and there isn't an answer, and I think maybe it's just maybe to provoke thinking. The big monstrous EHR vendors, right, are actually potentially creating more barriers to being able to move that upstream because they're optimizing their systems
Yes.
to basically align with the current conventional system. And the cost to change that actually falls on the burden of the health system or the providers, right? They actually incur the cost if they need a modification in the EHR system that they implemented. So that's like another real tension to
Yeah.
getting this to a more virtuous place.
And interestingly, like, HealthScape, where I work now, has partnered, we've got acquired by Chartis, and Chartis is a provider-facing consulting firm, and we, being a payer-facing consulting firm, are now starting to work together. And we're encountering exactly what you just said, that, like, they're working with Epic and trying to code the RCM processes in a way that might be contrary to what we're saying on the payer side. And, we're kind of trying to figure out, well, how do we eliminate that friction and figure out how to create a streamlined way of working together. The most inspirational projects that I'm working on are now working with a payer and their biggest provider partner and saying, like, why are we at odds with each other? And it's interestingly, um, some of those payer providers have never sat together except to negotiate a contract. They've never talked about the noise that they're creating with each other, within each other's processes, the RCM to the payer, the PI processes to the provider, and they never put it on the table and talked about it. And you're right that it's a lot of even their Epic use and, all of those Athena processes that are driving downstream problems as much as the other direction. And I'm encouraged that there could be a world where we're going to start like really sitting down and exposing all of this.
Lynn, this is an amazing presentation. You talk a lot about provider transparency and communication. When you think about payers and their commercial ASO customers,
Mhm.
and how do you think about more proactive and transparent ways that payers, particularly payment integrity leaders, can demonstrate value to their commercial customers?
So interesting that you asked that, because I, come from Cigna, and Cigna is like 90% ASO, and there's a revenue arm inside of Cigna of doing PI for those ASO clients, right? So there is a aspect of this that's almost contrary to how Cigna makes money, and all these big payers would make money on their ASO accounts. And I do think you have to sit down and draw out the P&L for them. And on one of my pushes with every payer that I talk to is, how do your actuaries think about avoiding claim denials? And kind of push their thinking in saying that a claim that never came to you it's almost like value-based care, right? Like, it's something that never happened is better than something that happened at a lower price. And that's the conversation we have to start having in this space too, to like kind of bring that thinking that something that didn't happen is better than paying contingency on something that you got to, because you avoided you got some savings on it. Right. So I think there's like just a change in mentality and a change in thinking that is going to take time for plans to all adapt. But I'm encouraged, again, maybe I'm just glass half full, that more than half of the payers I talk to will answer that question, that their actuaries are giving them credit. They are starting to think about it like that, and starting to mitigate trend is more important than the percentage of savings that they're getting.
Appreciate it very much, your presentation. My question for you is, in the battle between what I would say
downward pressure from a provider perhaps upcoding and a payer recoding to counter those changes. Do you think equilibrium will happen faster through a more human interaction where finding commonality and creating a workflow or process in which they help each other, or is it the aggressive application of AI on both ends? And what it really turns into is what you see in a lot of insurance arbitration, where it gets within 10% of each other and it automatically settles.
Gosh, I hope it's not the latter. But that's more of that dark side of you, isn't it? but I'm advocating for the former, like having that first upfront communication between the provider and the payer, and exposing the rules, and having a conversation between the medical directors and saying, like, when is it appropriate to be billing these diagnoses with these CPT codes? Can we all just agree on those rules? Because like, why do I need to go look through the EMR for it if I know what the rule is? So that means you don't have to send in all those medical records, which is their number one complaint. ED upcoding, sending in all those EMRs. They're very happy to stop sending them if we can all just agree on the rules. So I'm aspiring to a place where there's a human element up front of collaboration and agreement and rule setting, and we all agree on what it's going to be, and we can just all play by the rules, right? And then monitor that we're playing by the rules. I think that's achievable, right? And I don't see why we have to get into this contentious your AI, my AI, and and we can get to a place where we're just trying to do the best for patients. Because I think everybody can agree that there's just too much waste in how we're doing it today.
The last point you made in terms of making sure the rules are well understood. Now, most other payers, they do publish all the reimbursement policies and clinical policies. Is there a gap in terms of being able to effectively adopt them into the process, or are there any incentives given the RCM objectives versus the payment integrity objectives that are hindering the usage of those well-defined policies and rules?
Well, first I would argue that I don't think all the rules are exposed. They just say vague things like we're following NCCI, or we follow CMS. But if you really try to follow the CMS readmission policy, you'll find that there's lots of troughs. Is that a good use of troughs? Places where it's not so obvious, and there's interpretation to be had, and that's the places where I think you just have to be honest and upfront with your provider partners. I don't think they are being upfront, and in fact, some of the vendors that are out there are purposely keeping the rules a little bit vague. There's actually a rule that some vendors run that says 2 of the diags on this line don't go together. They're mutually exclusive. I can't tell you which ones. You may have sent 20 diags in, but I'm not going to tell you which 2 are wrong. And that provider has to keep guessing and resubmitting and trying to fix the diags, and they send it in 8 and 10 times. That's what I'm talking about. Can't you tell them which ones are wrong?
Why aren't they doing it? That sounds so counterintuitive to what they would want to.
Because the vendor gets paid a contingency if that claim gets denied. So it's to their benefit to keep the rules cloaked, to keep it very vague about how exactly why that was denied, because then the provider can't figure it out and they leave the money on the table. But that money's not really on the table, right? Because it's going to come back to the negotiating table. So how can we use technology to be more extremely communicative, transparent about which 2 diags were wrong? Why did you do that? And why does it matter? Can't you just fix it for that? Right? And I worked with a payer just yesterday who said, yeah, why can't we just change that claim and fix it? Add a line to put the diags in the right spot and we're done. Yeah, why not? Why do you need to deny it and pretend that you're making savings? Those are not savings. Those are just, and I think you said this, an opportunity for education, right?
Thank you.
What's the next question? So contingency built
This industry, but now it's really, it's really preventing us from transforming this industry. So
Yes.
where do you think it still fits? and where does it not fit?
That's a great question. And you know that I said in the beginning, my background was started at IntelliClaim, and we were the little startup. I said this last night to somebody that we built Claims Extend over a Dunkin' Donuts in Norwalk, Connecticut. And we were contingency, and we fought for every dollar, and we said our incentives are aligned with you, payer, and we're going after every dollar that you're going after. But I think, like, maybe there's a limit to how far that can go, and those contingency vendors have gotten a little bit too aggressive, and tried to be a little bit more denials, because that's how they make more money. So the payers have had to be very, very careful about how they use them and when they use them. So maybe there's a place where you put your administrative fees at risk, but taking a piece of the medical costs is maybe not something that they should be doing. Well, thank you for the opportunity to speak with you today.